Excuse me. We're all familiar with blood donation through the community blood supply, kidney donation from living and cadaveric donors, bone marrow donation for cancer patients, but we may not be aware of how important it is for brain donations in context of Alzheimer's research. Dr. Thomas Montine is the Alfred Endowed Chair in Neuropathology and Chair of the Department of Pathology at the University of Washington, where he is a professor of pathology and adjunct professor of neurological surgery. He is also adjunct professor of neurology at Oregon Health and Science University. Dr. Montine earned his BA in chemistry at Columbia, his PhD in pharmacology at the University of Rochester, and his MD and CM at McGill University in Canada, followed by postdoctoral medical training at Duke University. He's the president of the American Association of Neuropathologists, author of the recent National Institutes of Aging and Alzheimer's Association Guidelines for the Diagnosis of Alzheimer's Disease, and he's the director of the Pacific Northwest Udall Center of Excellence for Parkinson's Disease Research. Please welcome Dr. Thomas Montine.
Well, good afternoon, and thank you for the very generous introduction. Before we get started, I first want to thank Frank and Dave, Carl, everyone who thought to invite me to come down and speak with you this afternoon. I've had the great privilege of being on the external advisory board for the Alzheimer's Disease Center here at UCI. They are a terrific group, and I'll just stress to you, it's local. You all live here. They're your regional university. You really are blessed to have a terrific group of physicians, scientists, investigators, all committed to developing solutions for Alzheimer's disease. And I would encourage you to give them whatever support that you can. My name has been mentioned a couple times this morning. I don't know if Jerry Schellenberg is here. Jerry challenged me to stand up. Jerry, are you here? Let's see if Jerry, he said he wouldn't. I don't think he's here. It's hard to follow such a distinguished group of speakers. There was Howard Federoff, Jerry Schellenberg, Pete Nelson, Cordula, and the outstanding panel that we had, and then of course Liana just spoke. Those of you that have been sitting near me know that I've been quickly changing my talk so that I won't be just completely repetitious. So the topic that David assigned to me, or topics are here, the new guidelines and the importance of brain donation. Pete Nelson, I thought, just did a fantastic job this morning demonstrating the value of human brain-based research. And I'll touch on that some, but given the terrific job that Pete did, I've decided to focus my talk mostly on the new guidelines that have been developed at the national level. Liana spoke about some of them very briefly. There are others. It gets to be a little bit, when you're dealing with the federal government, it gets to be a little bit of alphabet soup with all the acronyms and this committee and that committee. But I thought it would be worthwhile to run through that with this group. It really is an example of what advocacy and what advocacy and elected officials together can do. So, to get into guidelines, this story starts with the National Alzheimer's Project Act, also called Napa. That was signed into law by President Obama in January of 2011, and in Napa, there's a plan, there's a specification, it's law, we're required to generate a national plan to address Alzheimer's disease. Several people in this room contributed to developing this plan. It's an ongoing plan, and I'll show you where we are at this point. The plan culminates by saying that our goal is to prevent or effectively treat Alzheimer's disease, including Alzheimer's disease-related dementias, by 2025. That's an ambitious goal. You've heard speakers this morning saying that we know lots about the clinical complexity. We know a lot about the molecular complexity. We don't have a correspondingly deep knowledge of treatments for the clinical and molecular complexity that is Alzheimer's disease. So we've given ourselves a deadline, and there are literally thousands of physicians and scientists around the world working very hard to develop those effective interventions. So scientific and medical input to Napa, right? So Napa, the Napa Council has lots of people are on that council. There are a few physicians, there's one scientist, there are lots of legislators and lobbyists and those sorts of people, and that's important because we're trying to be effective at the federal level. The plan specified that there would be expert scientific and medical input. So one of those was mentioned briefly this morning was the Alzheimer's Disease Research Summit in 2012. And again, I've put the link there because I believe these slides will be made available. If not, you can just simply look for the Napa Research Summit. This called together scientists from across the globe to develop a consensus on what were the most important research objectives that needed to be achieved and in what order they needed to be achieved. That was in 2012. In 2013, there was the Alzheimer's Disease-Related Dementias Summit, this one run by the NIA, which is part of the NIH. So I warned you there were going to be all these letters. So this is run by one organization within the NIH. This was run by another organization, the NINDS. This has a website as well, and these recommendations were recently published in a medical journal called Neurology. And I'll touch on what some of those recommendations are in a few minutes. Before I leave this point, I want to stress that as we get older, these diseases tend to converge in a given individual. And I've tried to represent that here. So each bar on this graph represents a brain donation from someone that was in that population-based study. And the color of the bar represents the type of disease that we identified. And the height of the different bars is whether there was mild, moderate, or severe amounts of that disease. So we're looking at individuals who had cognitive impairment or dementia, and we're looking at these three common diseases. And you can see Alzheimer's disease is blue, that if 3 means it's severe, right? So 1 is mild, 2 is moderate, 3 is severe. There are lots of people who have severe Alzheimer's disease as a major contributor to their cognitive impairment or dementia. But what's also very common is to have moderate to severe levels of small vessel injury to brain as well. And I'm suspicious that when sometimes we read in the newspaper that a group of researchers have discovered that an antihypertensive is lowering the risk of Alzheimer's disease, I'm not sure if that's true when I think of these data, and I wonder, sure, an antihypertensive may be lowering the risk of dementia, but has it really lowered Alzheimer's disease, plaque and tangle disease, or has it lowered this type of injury that's occurring in someone that also has Alzheimer's disease? So this is the clinical complexity of dementia that exists in the elderly and that we must deal with, right? You could ask the question the other way around. If we had a medicine that just made Alzheimer's disease go away in this individual that has severe Alzheimer's disease but also has severe vascular injury to brain, would they get better? Would they get completely better? Would they not get better at all? I don't know. But we have to sort through this. It's why biomarkers, as Liana was saying, is so critically important. It's why studies like Dr. Kawas's are absolutely essential, because this problem of comorbidity increases as we get older. It's less of a problem in people that have especially virulent forms of Alzheimer's disease that appears, as Ken Kosick was saying this morning, appear in individuals who are in their late 30s, early 40s. That tends to be Alzheimer's disease alone. But the public health problem that we face is in older individuals and comorbidity. The presence of more than one disease that will produce cognitive impairment is more common than having just one disease alone. So cognitive impairment and dementia is a syndrome, meaning that multiple diseases can produce the same clinical presentation, right? It's difficult to treat a syndrome. What you want to do is treat the individual underlying diseases, right? So that's the key point there. In older individuals, cognitive impairment and dementia is an idiosyncratic convergent trait, meaning that multiple diseases are combining to produce this clinical presentation. The most common diseases to do that, Alzheimer's disease is number one, followed relatively closely by vascular brain injury, then more distantly Lewy body disease, and further in the distance is hippocampal sclerosis that you heard a lot about this morning. And I'll pause briefly here on I didn't say this earlier, the vascular brain injury that we're observing in these population-based cohorts are all people that have ready access to health care. They all belong to either a managed care organization or have third-party payers, right? We have what is completely transparent to us are individuals that don't have ready access to the healthcare system, and based on the epidemiology, there's every reason to think that this is a larger problem in that group. Cognitive impairment dementia are caused by these diseases, and all of these diseases are chronic diseases. It sounds silly to say this to this group because you have lived with it, but no one wakes up one morning with dementia, right? It just doesn't happen. So there's a prodromal phase, which we clinically operationalize as mild cognitive impairment, and we had compelling witness to that by the panel that we saw earlier this afternoon. And then we also have this latent group or preclinical group or asymptomatic group. There are lots of words for it. What we're trying to describe is that disease is present, the disease has started, but there's absolutely no manifestation of that disease. That's, again, one of these good news, bad news things. It means that when we say that there are millions of people with Alzheimer's disease, there are, in fact, many millions more, because we're talking about people with dementia. So there are many millions more people with Alzheimer's disease, but they don't know it. And that's a window of opportunity to treat, right? If you can treat a disease before it has any clinical meaning, you've effectively cured it. I added this slide to underscore the molecular complexity. So we've talked about the clinical complexity and how that reflects itself in the pathology of these diseases. And then there's the molecular complexity. And Jerry Schellenberg is the world's expert at genetics of this complex trait, this complex convergent trait, and genetics is the key to figuring out the molecular drivers that underlie Alzheimer's disease and these other diseases that cause cognitive impairment. I'll pause here for a moment. Jerry talked about the IGAP study and the loci that we were able to identify. He also mentioned a study run by Gary Beecham and I, where we tried to match, so we've been able to identify genetic loci that impart risk for the clinical presentation of Alzheimer's disease. And then we said, well, what about the genetic risk for these structures that are so characteristic of Alzheimer's disease, the plaque and the tangle? And that was the purpose of the study that we ran, again, based entirely on brain donations, right? So this would not have been possible without what I think are courageous and selfless decisions by 6,000 individuals around the globe who donated their brains for research. And we're able to match the different genetic loci to the different pathological structures, all but one, which I think is intensely interesting, CR1, which is an inflammatory pathway. All but one of these genetic risk loci match to, for the clinical presentation, match to a pathologic structure. CR1 doesn't, which raises the question, is CR1 related to the clinical penetrance, right? Is alterations in the immune system related to the clinical penetrance of the disease, but not actually progression of the disease? And that would be an alternate therapeutic approach then. So back to our guidelines with that background. Recently, as a result of the summit in 2012, right? So there was Napa in 2011, the summit in 2012. From that summit comes the scientific input to the national plan. The first step of that scientific input was to have this summit sponsored by the NIA. The outcome of that summit was to develop guidelines for the diagnosis of the dementia stage of Alzheimer's disease, for the diagnosis of mild cognitive impairment due to Alzheimer's disease. And so I have the leader of the group was Guy McCann, and then the reference for those of you that are interested, and then what Liana touched on, guidelines for dealing with the preclinical stages of Alzheimer's disease, where our knowledge is most sparse, so we tried to be conservative in our title, and Risa Sperling was the leader of that group. Brad Hyman and I were asked to lead the group to develop guidelines for the Neuropath assessment. I'll show you those briefly, but you've heard a lot about those already, and then there are the references for those. In 2013, the NINDS and the NIA assembled the Alzheimer's disease-related dementias summit. So the first summit, scientific input that was prescribed by law, was for Alzheimer's disease. But if you remember back to that quote, our charge is by 2025 is to develop prevention or effective intervention for Alzheimer's disease and its related dementias. Why? Because, as I was just explaining, many of these diseases converge in an individual, and so just developing solutions for one may not be sufficient. So the related dementias, that we haven't heard a lot about these today, but there's a condition called frontotemporal dementia that, as Liana was explaining, different cognitive domains typically are affected in frontotemporal dementia than Alzheimer's disease. Often there are behavioral variants within frontotemporal dementia, much less common than Alzheimer's disease, just as devastating as Alzheimer's disease. I've already talked about Lewy body disease, vascular brain injury. There was a whole section devoted to multiple etiology, which is just a sort of scientific jargon for saying we recognize that there's this comorbidity problem and we need to deal with why in most individuals there is a convergence of multiple diseases. And then importantly, health disparities issues that Amy will talk about next. And then the reference for that was just published last month. And then I'll mention briefly, although not a focus of this group, the NINDS also sponsored a similar summit for Parkinson's disease, both motor and non-motor symptoms, and it has been very poignantly recognized in the last 5 to 10 years that although the motor impairments of Parkinson's disease are devastating, we have reasonable, effective interventions. Because of those, the non-motor symptoms of Parkinson's disease are now gaining greater recognition. And cognitive impairment is number one. About a third of individuals with Parkinson's disease have substantial cognitive impairment at the time of initial diagnosis, and almost 80% of patients with Parkinson's disease have dementia by the time they're 10 years into their disease. The type of dementia is different than Alzheimer's disease, but these people also are suffering. And it's our expectation that as we develop solutions for one, either Alzheimer's disease or Parkinson's disease, it will illuminate pathways to success for the other. I was specifically asked to talk about the Neuropath Guidelines, and so this is a list of my colleagues that helped develop these guidelines with Brad and I. There are some important changes that we made in 2012 over what was done previously in 1997. The first, previously we required that this clinical state of dementia existed before we would make a neuropathologic diagnosis of dementia. That idea is hopelessly out of date, and if you recognize immediately, then we couldn't diagnose Alzheimer's disease in someone who had mild cognitive impairment for dementia. Just wasn't allowed by the criteria. So that was just a logical problem with the current criteria because they were based on older knowledge. So we removed that requirement. And then we opened up the methods that we use to assess plaque formation. That N stands for neuritic plaque. It's just simple enough to say plaque. Liana was just showing you how she images those plaques. We have protocols for observing them in tissue, and we added a new way of doing this called Thal phasing that's based on antibody staining and not restricted to essentially the method that Alzheimer himself used. The advantage of that, I believe, is that it will allow us to more closely correlate what we observe in brain donations with what Liana and her colleagues observe through imaging studies. 1997 offered little to no guidance in how to evaluate common comorbid diseases that several of us now have talked about. We provide explicit guidelines on how to deal with that, because we now recognize comorbidity is the most common situation in the elderly. And then we provide guidelines on how to carry through this evaluation and how to report it. So I hesitated on whether or not to include some of these slides because it gets to be very esoteric. The point of this slide is that we have a fairly complicated rubric for establishing whether or not Alzheimer's disease is present in a pathologic specimen in someone's brain. And then we use that rubric to make an estimate of how severe those changes are. So we evaluate amyloid with an antibody stain, and that's the closest we think we can get to talking the same language as the neuroimagers when they use their PET staining. We then use another measure to assess neurofibrillary tangle and the extent of neurofibrillary tangle disease. So Alzheimer's is this funny condition where there are two things going on simultaneously, and it remains, and Frank is one of the world's experts at this, it remains the Nobel Prize winning question of what connects these two, but there's plaques and tangles, and how they're related mechanistically remains an enigma. So we evaluate amyloid, we evaluate tangles, and then we have a measure of what are called neuritic plaques, which we think are closer to a measure of neuron damage than simply amyloid accumulation. So a measure of amyloid that correlates with imaging, a measure of tangles because it's this other facet of Alzheimer's disease closely related to cognitive decline, and then a measure of neuron damage. And then whether they're high, intermediate, or low levels, we declare the extent of Alzheimer's disease present in an individual's brain. Just like Liana said, sometimes there are foolers. Sometimes there are individuals that have been seen in research settings, diagnosed with Alzheimer's disease, and it just doesn't turn out that way when we evaluate pathologically. That doesn't happen all that often, but it does happen, and those are very informative cases, right? That individual's experience is very informative to us and helps us improve our diagnosis so that we manage patients appropriately. Just to show you a few images then, these are sections of brain. So let me do this in chronological order. So someone is part of an Alzheimer's center, like the center here or the center in Seattle. They pass away, and before they've died, they've volunteered to donate their brain for research. And we go through a big procedure to be sure that we maximize the research utility of each and every one of those donations. In addition, we diagnose what were the diseases that contributed to cognitive impairment and dementia in that individual. So if you would imagine someone that died after a course, say a 10-year course of dementia, and that we were to use an antibody, which is a type of protein, to recognize amyloid beta, which is another type of protein. And the protocols that we use, that purple is just the tissue, and brown is where the antibody binds. So these are all amyloid, these brown sort of clouds are all amyloid deposits in the highest functioning part of our brain, the cerebral cortex. And what's often not appreciated is that amyloid accumulation is widely distributed in brain, so in the cerebral cortex, but also in a less advanced, less evolved part of brain, the neostriatum, and even in a part of brain that to a first approximation, we don't use to think. We use it for controlling movement. Amyloid accumulates there as well. This is simply to show you an image of the neurofibrillary tangles here. And Liana has shown you pictures of those already. We take the same approach with Lewy body disease. Lewy bodies are composed of a different protein, again, identified primarily initially through genetic studies. That protein is called alpha-synuclein, and so we use an antibody to alpha-synuclein to identify, so brown again is positive, to identify where the alpha-synuclein is accumulating in brain. It accumulates in regions different from where the A-beta accumulates. Nevertheless, Lewy body disease and Alzheimer's disease also have this enigmatic connection. It's not as tight as the plaque and tangle connection, but there's some connection between these two molecular processes. And then finally, cerebrovascular disease. I'll show you an example. So there are two aspects to cerebrovascular disease. One is that the vessels that penetrate into your brain, that bring blood to your brain, they can be diseased and reduce the efficiency with which blood is delivered to brain. Or they can be so severely damaged that the brain itself then is damaged, if that makes sense. So I'll try to be a little clearer about that. So this is a section of brain. That's a blood vessel. This is magnified many, many times. And that blood vessel wall, so take my word for it, that's healthy. And then what begins to happen is the wall becomes disorganized. It becomes replaced by this pink tissue, and ultimately it can split. So normal, mild, moderate, severely affected small vessel disease. The brain around these vessels looks okay, but the vessels are diseased. When the vessel disease gets really severe, then the brain itself is damaged. So I picked one example that you could just see with your eye. This is a coronal section of brain. These two holes are normal. Those are the ventricles that we all have within our brain. That hole is not normal. That's a small stroke. There it is at higher power. So when the vessels become so diseased that the blood is no longer delivered to that region of brain dies. Brain is unlike other organs in that that dead tissue is replaced by nothing. It's just carted away, and you're left with a hole. That's large enough to see with your eye, and here's one of these very small ones that as individuals accumulate those in their brains, thousands and thousands of them, it masquerades as the dementia syndrome. This infarct would be recognized clinically. It's a stroke. It's a small stroke, but it's a stroke. Injury this size is not recognized clinically, but as I said, as it sums, it masquerades as the dementia syndrome. So to summarize then, what are the major challenges that remain? As you'll hear in the next talk, almost all of our knowledge about dementia in the United States comes from people of European descent. There are a few exceptions. The study run up at Columbia, studies run here at UCI, but they're the exception. And this is a major gap. There's a major gap in our knowledge. We have incomplete knowledge about disease mechanisms, and that's for the individual diseases. We have very limited knowledge about this comorbidity state, which is the most common human condition, right? The way we're going to gain that knowledge is to develop representative experimental models, right? Animal models that reflect the human condition, which is a complex state. But until we develop those models, I think we're still going to be grasping for what are effective interventions. And the people here at the UCI Alzheimer's Centers are the world's leaders in that. So next steps around guidelines. We are currently working with Napa to update our milestones. So these plans are evaluated every year, and we have to provide to the U.S. Congress our progress in reaching milestones. So we are currently updating our milestones. In February of 2015, the second Alzheimer's Disease Research Summit will be held on the NIH campus. Everyone is invited. So this will go up on the website, and if you feel as though you can contribute, please register and join us. In the winter of 2016, we'll have the Alzheimer's disease-related dementia summit, the second one of those, and then just to remind everyone, right, when we get to that point, which is a year and a half from now, we're 9 years away from our target of 2025. When we need an effective prevention or treatment. So thank you very much for your attention.